Welcome, everyone. Thank you so much for joining us today. We're going to wait another minute or so to have some folks join us. And as you join us, we hope that you're also joining us in the Adobe Connect webinar room. We would love to hear from you. If you could list your state and jurisdiction, your title, and your area of focus in our chat below the slides. We would love to hear from you and see who's in the room. So thank you so much for joining us today. I see Andra and Larry have said hello. And we do encourage you to mute your phone lines. We do have the phone lines open. Because we do encourage you to speak up and ask questions verbally. So if you could please mute your phone lines, keep that in mind throughout our time today. And you can always unmute yourselves at the time when you'd like to speak. So hi, Nicole. Hi, Lisa. Thank you so much for joining us today. Great. So we have a great webinar today for you. We're going to be talking about health equity, and we will leave the little chat box under there as we continue along, because we would love for you to all introduce yourselves as we get started here. So thank you for joining our State Technical Assistance webinar today. We are very excited to have you all with us. We are funded, the Children's Safety Network is funded by the Health Resources and Services Administration of the U.S. Department of Health and Human Services, and we are HRSA's primary vehicle for training and technical assistance on child and adolescent injury and violence prevention. So some technical tips. Please, as I mentioned before, please mute your lines as our phone lines are open. We have today's slides in the download pod at the top, and we also have some web links to some important things like our Health Equity Planner today and our Cohort 3 application. You can use the chat pod that will be on the bottom left throughout the rest of the session. And this session is being recorded and will be posted on our website shortly. So I'll introduce all of the presenters. My name is Maria Cotratis. I'm a Senior Training and Technical Assistance Associate at the Children's Safety Network. We also have with us today Jennifer Leonardo, who's the Director of the Children's Safety Network, Jenny Stern-Carasone, who's the Associate Director, and our colleague at PIRE, Bina Ali, who's the Director of CSN's Economics and Data Research Center at PIRE. So thank you all for joining us today. So our agenda for today is that we would love to get to know you a little bit more. We'll get started with defining health equity, and then we'll go into a brief conversation about how we identify health disparities in child and adolescent safety areas. We'll discuss some resources for advancing health equity, and then we'll do a deep dive into using the Health Equity Planner and how we can, we at CSN can help support you in this work. So here we would love to hear from you about what do you need to start working on health equity. And you can unmute yourself. And we know there's a question at the bottom, and you can check all that apply. So we really want to know which of these areas are most important for you to address in order to get started on implementing health equity approach to your child and adolescent injury prevention work. So we see a number of folks are putting in staff capacity, leadership support, a common definition of health equity, tools and resources. So we see that all of these are important, and some of the highest chosen ones are financial support and staff capacity. Great. So we see that we need all of these different components, and some of you need some of the components more than other components, and we see that financial support and staff capacity are definitely the highest, and they're constantly moving up. So thank you for letting us know a little bit about what your immediate needs are. So to get started, we want to start with a common definition or a working definition of health equity that also serves as our ultimate aim in this work. And we particularly like this definition from Whitehead and Dahlgren, which is that health equity is the attainment of the highest level of health for everyone, and no one is disadvantaged from achieving this potential because of any socially defined circumstances. Of course, we understand the role of social determinants of health resulting from socially defined circumstances that play a huge role in achieving our ultimate goal of health equity. And so now that we've defined health equity, we'd like to talk a little bit about health inequities versus health disparities. So here we see a clear comparison between inequities and disparities. Health inequities are avoidable differences in health outcomes that are unfair and unjust, while disparities are observable differences in health outcomes between groups. When inequities are defined and identified, we ask, is the disparity in rates due to the differences in social, economic, environmental, or healthcare resources? While for disparities, we ask if there's a difference in rates between population groups. It's important to understand this distinction because by identifying disparities between population groups, we can begin to unpack the inequities that have led to those disparities. I would have passed this over to our colleague Bina, but she has lost her voice today. So you can introduce yourself, Bina, if you'd like, and then I'll take over your slides.
Good afternoon, everyone. I'm really excited to have you all here today. I wish I could present. I'm feeling okay to be here, but my voice is not okay. So I'll be here. So if you have any questions, feel free to ask them. I'm using chat, and if I need to, I can also jump in to answer any of your questions. Thank you for being here. Thanks, Maria, for presenting.
Thanks, Bina, and we totally understand. So thanks for introducing yourself. So health disparities is a metric that used to measure progress toward achieving health equity. Racial and ethnic differences are noticeable across injury intent types. So this graph shows injury rates by intent categories across different racial and ethnic groups. Unintentional injuries mean accidental injuries from various causes such as motor vehicle traffic, poisoning, firearm, fire and burn, drowning, cutting, piercing, suffocation, and falls. Homicide refers to injuries inflicted by another person with the intent to injure or kill. Suicide includes intentionally self-inflicted injuries that result in death. Injury deaths that have sufficient information to identify intent type are labeled undetermined. Another intent type is legal intervention injury deaths that include injuries inflicted by the police or other law enforcement agents. The number of legal intervention related injuries are too small to look at separately, so they're combined with homicides in this graph. This graph clearly shows that unintentional injury data and suicide rates are highest among American Indian, Alaska Native children and adolescents. Unintentional injury and suicide rates in American Indian, Alaska Native children and adolescents are approximately twice the rates of their white counterparts. Black children and adolescents have the highest homicide-related injury death rate. Homicide rates in Black children and adolescents are nearly 8 times the rates of white children and adolescents. Cultural and social level factors such as poverty, cultural disconnection, stigma, alienation, and limited resources and services, and various other factors contribute to these disparities. Unfortunately, disparities persist among U.S. children and adolescents ages 0 to 19, despite improvements in injury prevention achieved through the identification and implementation of best practices. We see injury differences across race, ethnicity, sex, socioeconomic status, sexual identity and orientation, urbanicity, health literacy, and disability. And in CSN, we use the socio-ecological model to help us understand and address the factors that put people at risk for experiencing injuries and violence. So here's another data slide that shows disparities in male versus female children and adolescents. Across all injury types, male children and adolescents have higher rates of injury death compared to their female counterparts. Unintentional injury death rate is 70% more in males versus females. Homicide and suicide-related injury rates in males are approximately 3 times the rates that we see in females. Disparities are apparent in data by location where children and adolescents live. An example of that is urbanicity type. Unintentional injury death rates, suicide, and undetermined death rates are higher in children and adolescents living in non-metro areas. However, homicide death rates are higher for children and adolescents in metro areas. These differences can be attributed to environment and access to resources and services. So how do we identify these differences? We look at data. No one data source gives us a complete picture of health disparities and health equity issues. In CSN, we rely on multiple data sources, and some of the data sources that we rely on are listed here. We look at national and local level data on deaths, hospitalizations, and emergency department visits as they are made available. We also look at surveys that provide information on risk factors and protective factors at individual levels and broader community and societal levels. Use of multiple data sources allow us to understand not just the type of individuals who might be at higher risk for injuries, but also the context that they live in and the conditions that might affect them. In CSN, we provide technical assistance on identifying and using different data sources to guide child safety work, and we also develop resources using these and several other data sources. So here you see that we have a number of CSN resources aimed at advancing health equity. One is the CSN Framework for Quality Improvement and Innovation in Child Safety, which is a guide to implementing injury and violence prevention strategies and programs. The CSN Health Equity Planner that we're taking a deep dive with you today during this webinar will help you get started on a systematic approach towards health equity and child safety programming. And we are also working on a forthcoming health equity tool with the National Center for Fatality Review and Prevention and Safe Kids Worldwide. So we look forward to sharing that in the near future. And now I'll pass it over to my colleague, Jennifer. Thank you.
Thank you, Maria. I'm going to talk about the Health Equity Planner with you and a little bit about CSN and how we arrive at some of these resources. We're very fortunate to work hand in hand with the Children's Safety Now Alliance, or the CSNA, and with Title V agencies who are on the ground working on health equity. The CSNA is a national alliance made up of 46 member organizations, 5 federal agencies, 7 state agencies, 3 hospitals, and 21 national organizations. This group has depth of expertise across a number of child safety topics, systems development, health equity, cross-cultural issues, and using data to inform decision-making. They've reviewed and provided valuable feedback on the Health Equity Planner that we will go through today. Title V agencies and a lot of the folks that are in this room with us today have been working through the CSLC, or the Child Safety Learning Collaborative, and some of you have piloted the Health Equity Planner for us and participated in focus group discussions that enabled us to finalize this resource. The CSN Framework, which is how we organize our approach to child safety at CSN, was based on the CDC Social Ecological Model, the Framework for Prevention, the Institute for Healthcare Improvement's Breakthrough Series Model, the Associates in Process Improvement Model, and FSG's Collaborative Impact Approach. So we have a lot of theory behind this model, and we also have a lot of empirical evidence that we have been gathering since 2015, and we're starting to see some results in using this model in advancing workforce development and achieving results in child prevention systems. We believe that this will then associate with increased positive health impact. The planner is organized to follow this framework, and we will take you through that. There are 5 sections: the social determinants of health, the scope of work, leadership and management, child safety expertise, and systems improvement. And 3 of these 5 sections are from the framework that I just showed you, and those are leadership and management, child safety expertise, and systems improvement. In this planner, we also are trying to offer you a very practical approach to working on health equity. And we have found that using a quality improvement approach has yielded successful results and sustainable results. So you're going to see that for each of these 5 sections, there will be a series of detailed questions that follow 3 phases of quality improvement. The first is to assess your current situation. The second is to plan your work and test those child safety strategies and programs, making sure that they fit your local context. And then the third phase is to monitor the work that is going on and make any revisions or adaptations that are necessary. We want this planner to be something that offers you a practical guidance on working toward health equity. We know it is a very large area to be working in. We have heard from many states that people feel overwhelmed. They don't know where to start. They don't know how to start. So our intent is to offer you a tool that you can use either as a department or agency as a whole, or as a program or a work unit. You could fill it out as an individual, and then you can talk about it with your colleagues, or you could fill it out as a team. You could go through this from start to finish, page 1 all the way to the end, or you could look at the sections that you want to work on or that you think you need more attention given to, and just work on those particular sections. Really, the idea is that we would like you to get started. It's the quality improvement spirit of how can we take one step forward and what is that next step. The overarching questions in the planner that correspond to those 5 sections are: what social determinants of health most affect the communities you serve? Does your department or program have a shared aim statement for addressing health inequities? Do your partners share the same statement? Who will champion and institutionalize health equity in your department or program, and how will they do that? Are you engaging a diverse community of stakeholders and spreading evidence-based and evidence-informed, culturally tailored child safety strategies? Does it fit your local context and your community's needs? What indicators will you use to assess progress on reducing inequities? So how do you know that you're making improvements? I just want to take a moment to pause here and see if there are any questions. Please feel free to unmute yourself and just ask a question, or go ahead and put that question into the chat. And I also believe that you should have had a link that was provided that opens the Health Equity Planner for you. And we are going to take a couple of minutes after we answer any questions to have you scroll through, look at this planner, and then we'll take you through selected sections and we'll have some discussion. We have a good comment here from Bina in the chat that you should be looking at the planner as a living document. Revisit it as often as needed. This document is electronic. It's fillable. When you start to type into it, those text boxes become scrollable so that you can save your work, share your work, and revisit it over time. Okay, we'll just give you a couple more seconds to see if there are any more questions that pop in. And if you have questions as we go through the different sections, please feel free to put those into the chat. All right, I think we can jump right in. So I'm going to hand this back over and give you all the opportunity to look at the social determinants of health section of the planner.
Thanks, Jennifer. This is Jenny. What we'd like to do over the next 20, 30 minutes or so is to really just open this up for a conversation and to be able to look at parts of the planner to help fuel that conversation and start talking about kind of the framework of how to think about applying a health equity lens to your child and adolescent injury prevention work. So once again, the planner should have opened in your browser, and if it did not, you can click on the link that Kate put in the chat so you can access the live document and be able to explore and look around. Page 4 of the document, as Jennifer noted, has the navigation page where you can actually click on the section headers and it will take you directly to that portion of the planner. So we're going to use the planner as our conversation guide, and I want to start with the social determinants of health. As we did in this presentation today, we started with talking about disparities and the data that's available that really drives the need for applying a health equity lens to our work. And these disparities derive out of social determinants of health. And so considering the social determinants of health is really essential in starting your health equity work in child and adolescent injury prevention. It's important to look at the social determinants of health being things like housing, quality and access to social services, education, health care, geographic location, and so forth. This is probably very familiar to many of you, as you often are looking at social determinants of health when you're starting any of your strategic work and setting forth your proposals and establishing the need for the work that you are doing. So this is often where you might already be working with your epidemiologist or other data managers to obtain the data on health disparities for the populations that you are addressing. And so starting from that foundation, we also in the planner have started from that foundation. Once again, the planner is designed for each of the 5 areas of the planner. It is designed on 3 different levels. Assess, and this is the quality improvement layer, where you start by assessing and really looking at what's happening and getting a baseline. Then once you have that baseline data, then the next step is getting into the planning and testing phase of your work in this area. And finally, it would be the evaluation and monitoring component. So again, the planner itself is set up with those 3 different levels, and within each of these areas, such as social determinants of health, then also designed to be used either at a project level or at more of a department agency level. So here in the social determinants of health, one of the key questions in the assess stage is, what social determinants of health indicators are you looking at to help determine what your need is and what direction that you need to go in? Kate, if you could move us to our discussion layout. So thinking about what data is out there and what access you have to it, one of the first steps is really, what are the facilitators? What makes it easy for you to get this data that is so critical to helping to inform the work that you're doing? Or what are the barriers? So down here at the bottom, we've provided 2 chats for those of you that need to kind of think and write before you start speaking. And so you can start thinking about, what are the facilitators that are available to you in helping to use data to identify disparities and inform your work? Or what are the barriers? Do you have an epidemiologist readily available to your team in the work that you're doing? Or do you have real-time data sources that you're already using? And if not, what's the inhibitor? What are the obstacles? This is our state technical assistance webinars are intended to be a technical assistance opportunity. So I am going to call on people. We have our phone lines open, and we have you on the phone instead of just a listen out, because we really want to hear from you and be able to have you guys listen and hear to one another. So Andra, I'm going to call on you, since you've been so brave and put something in the chat already, and talking about the fact that there's a real lag on data. So in Missouri, what are some ways that you've tried to address this lag to help keep yourself informed in the work that you're doing?
Well, I mean, overall, public health data is usually going to be a couple years behind because of, how data is. We are working to partner with our group using Essence and looking at other ways to get some of that data just in general, not specifically around the social determinants of health, but looking at ways to kind of get some better real-time data that we need.
Great. That's great. Is that resonating for others in terms of, we're all having to contend with the fact that much of the data that we rely on to identify disparities is really, has a huge lag. Are you following similar kind of process to what Missouri is doing. Kim, you're talking about getting access to local data, that's an inhibitor for you. What's the inhibitor to getting the local or county level data?
Yeah, a lot of it just has to be suppressed because of state policy. And so it's hard to get, especially in our more rural counties. So it just has to be suppressed to remain, to suppress the information so people aren't identified or certain areas aren't identified. So that's a big issue that we have, is to getting our rural counties that really need a lot of support and getting that local data, meaningful data to help us with our work.
Yeah, and that's another big issue is, especially in well, the disparities are significant, that oftentimes our population base, creates this issue of needing to suppress the specific statistical numbers because of the small numbers that they are, and that does make it very difficult. And I know that, Jeannie, you also talked about not knowing what to ask for is another inhibitor, and making it difficult to know what's available. So in thinking about getting over some of these inhibitors of the delay in data, and Nick said this is true in Michigan as well, and also in Louisiana, Jane, you talked about here on facilitators having great EPI staff and agency focus on inequities. Can you share a little bit more about that facilitator and how it helps you to mitigate some of these barriers that everybody is experiencing?
Sure. Hi, Jenny and everyone
Hi.
else. This is Jane Herway from Louisiana, Bureau of Family Health, and we have we have an EPI team, and so we typically have an epidemiologist who focuses on injury specifically, but we also have other EPIs that work in different areas, and we have a health equity sort of action team that looks at data through an equity lens. So we have a real kind of focus on that within our agency. And we're lucky in Louisiana because we're situated within the Office of Public Health, so we have a ready access to the data that are available. So whether it's the BRFSS data, the YRBS data that the Office of Public Health collects with the Department of Education, the vital records data. So it's not like we have to wait for a long time to get data. Sometimes it is delayed because it is public health data, but we do have ready access to many data sets that we need. So those are facilitators for us.
That's fantastic, Jane, and that really resonates with what Jennifer had put in the chat above you, and having this close relationship with your state epidemiologist or other data sources. Has this, access and relationship across different facets of the state public health department always existed, or did you have to help to encourage some of those relationships over the course of your work?
Well, I've only been with the State Health Department since the end of 2013, but I think a lot of it has, kind of predated me. Our injury program is situated within our Title V, our maternal child health program, and so in that initiative we have what's something called an SSDI grant, a State Systems Development Initiative, which really emphasized access to minimum and core data sets that are important for maternal and child health, population monitoring, and so I think we've always had a really strong relationship. There are certain things that we still have to, sometimes it's more difficult for us to get Medicaid data. We can, but it's through a separate request process. It's not like they send us those files every month, So, I think there are data sharing agreements and certain things that we have in place, but it really is a very strong relationship between the different bureaus within the Office of Public Health and the data that we all are able to access. And then I would say in about 2015, we added a Bureau of Health Informatics that also kind of is the steward for many of these data sets. So, for example, Vital Records lives with, health statistics or whatever, but then they send files to each bureau, but also their files that are maintained through the Bureau of Health Informatics. Same with the BRFSS data, and other data sources that we use. And then we also have, like for
some of our motor vehicle crash data. That's owned by the Department of Transportation Development, and we have agreements with them. And there is some legislation in Louisiana that does facilitate sharing of data between state entities. So I think it helps that we're a state health department. So I don't know if that answers your question, Jenny.
No, that was excellent. And you've done such a nice job of really kind of outlining a couple of other key components where, again, in the use of the tool, we're encouraging, really breaking down the various steps that it takes to organize and develop these systems that you just described, Jane, of, you talked about ownership in different departments and different agencies, and yet you have agreements that enable you to be able to exchange that information fairly easily. I would love it if you could put some information in the chat about the systems development grant. I don't know if that's something that's available throughout the country that other states could access, but that would be a great resource, and I'm not familiar with it, and I'd love to explore it more as well. So, that's excellent, and that is, again, part of the systems approach is really, thinking about designing this kind of potential and capacity for the flow of information, acknowledging that information is seated in many different places. So we're going to shift here in a moment to talk a little bit more about the application of data in helping to promote your awareness and use of the social determinants of health in this. But Jennifer, as we do that, could you just speak briefly to the comment that you put in the barriers about rolling up data?
Hi, Jenny. I'm just looking to see where my comment is there. I don't see it. If you can read it to me.
Oh, sure. You wrote, data can be rolled up and you need to drill down within the social determinants of health to best decide what intervention to implement.
Thank you. Yes, I'm thinking of categories that we use for social determinants of health, like housing, for example, or education. And sometimes the data are rolled up into these larger categories, and you need to have access to see how that category is being operationalized, or to have another survey that dives deeper into those categories. So like the YRBS is a really nice example because that dives deeper into the behaviors of adolescents, so that you can then say, oh, all right, let me look at these select behaviors, and then let's see if there's a particular child safety strategy or program that's getting at those risk factors, and let's implement that. So when I heard Jane speaking, I was actually very happy because she was saying that they round out the data and have a lot of additional surveys that they're able to look at.
And that's a really nice transition to this kind of second layer of discussion questions about using data over time to drive your decision making and to monitor the changes. And again, that's moving into the planning and testing and the and the evaluation and monitoring aspects of the tool. So before we shift to another section of the tool, I just wanted to give a little time for this. Thank you, Jane, for sharing that information. I'm going to stay in this layout so that if people want to copy and grab that information that Jane just shared, they can. So I understand that my two chats are no longer aligned with the questions above. But this, again, is a training and technical assistance opportunity. So I think it's most important to make sure people can get that information that Jane shared. And I want to continue to encourage us to just keep sharing information. So what are some examples that people can share about how you're using data over time to drive your decision making or to monitor the changes and in terms of the health disparities and trying to achieve health equity? I know many of you are here from and are also participating in the Child Safety Learning Collaborative, where routinely we are looking to use data to really drive our decision making, to, as monthly data is collected, to look at that and to identify where there are ebbs and flows in your process that help you to determine, am I doing the right activities for the time of year? Am I using the right methodology or tools to reach the population that I need to? Is this evidence-based practice the right fit for the work that I'm trying to do. So I know some of you have examples of how you're using data over time to drive decision making as well as to monitor changes.
Hi, Jenny. This is Jennifer jumping in. Just looking at that second question, how do you use the data to monitor changes in health disparities, and thinking about the number of comments around the lag of availability of data. And I wanted to say that, especially in the CSLC, I know there's a lot of effort to track and monitor the implementation of your strategies and to really try to sustainably and widely spread those strategies. And I think that's a nice approach when you have a data lag at a health disparity level, that you've identified the program that you believe is going to help address that inequity, and that you're tracking, are you getting enough reach in that interim period from having your health equity data come out again, maybe a year or 2 years later.
That's such a great point, Jennifer, and again, raises the essential point that, when we talk about data, that data can come from so many different sources and in so many different forms. Oftentimes we looked to these large data sets that do have inherent delays and so forth, but there's a lot of other in the moment data, process data, that can be really effective in helping to continue to inform and guide the work that you're doing. Jane, I see you've added in about Louisiana's use of data to drive drowning prevention efforts across the state where there are higher rates of child drowning and free resources. Did you want to explain that a little bit more before we shift?
No, not really, but it's not that I don't want to. I don't know that I have that much to say. So I see Kristen Sanderson is on the call too, and she's the manager for one of our Consumer Product Safety Commission grants, which is wrapping up now, which is the Pool Safely, not safety as many people think, it's Safely with an L-Y initiative. And when we were planning that grant and writing the proposal, we used our child death review data, and so to look at areas of the state that had higher rates of child drowning. We looked at some of the data from the case registry and what came out of child death review on some of the circumstances contributing to those drownings, and then we looked at community resources in areas for free or low-cost water safety or swim instruction, and then we built the program around that, and we're able, through that initiative, to set up what I think are really some cool and innovative partnerships with different providers that were able to kind of sort of transport their model of swim instruction to communities that didn't have, an active YMCA or a strong recreation department or didn't have pools. So this model actually took certified instructors and paired them with a partner organization that had a pool, and then was able to offer lessons during the summertime, and then had some other initiatives as well. But that's essentially one of the things we did there, looking at, where there were, with injury a lot of times, especially with drowning, kids don't, maybe in their community, don't have access to those resources. So trying to figure out a way we could import sort of those resources to communities that didn't have any. So that's all. Kristen, is there anything else you want to add?
No, I think you covered it.
That's another really strong example, again, of, that real flexibility that, when you have data-informed decision processes and the ability to monitor and continue to make those changes based on data, that you can really then adapt the work to fit different sectors or regions of your state and fit the resources that are or are not available. And that's just such a great capacity to have, because we're constantly having to address a variety of disruptions or other capacity limitations, and it's great when you can use data to help to inform and drive your work, but also to give you that flexibility. I'm going to sum up. Jeannie, you had mentioned that you're doing some work combining survey data with health data. I'd love to hear a little bit about that before I hand this off to Jennifer to talk about a different section of the planner.
Sure. We do work with a lot of data from our highway safety office. My focus is on teen driver safety, and so we're taking data from highway safety. The maternal and child health needs assessment is where we saw the data come up about disparities and amongst teens, and it's demographic as well and culturally as well, and so we're taking all that data but also combining it with the surveys that we do with teen drivers in our schools, and to show kind of different areas of the state have different issues when it comes to teen drivers. Low seatbelt use in one area, high seatbelt use in another, and so then we're trying to adapt materials and things to address even geographically the differences within the same population. And with the disparities, that's something that we haven't taken a deep dive into yet, and I'm wanting to use the planner that you have to be able to reach our populations of Native American and African American teens, and looking at economics and driver's education and opportunities that they may or may not have.
Great. That's wonderful to hear, Jeannie. And again, you're bringing forth that point that the intention of the planner is to help you to really break down the work that you're doing so that you can bring in this lens of thinking about, am I doing the work to reach the populations and serve them appropriately? And as Jane mentioned, that sometimes you've got resource limitations or other issues that are regionally based. You also got cultural considerations that you need to consider, and so it doesn't mean that the evidence-based program that you're using is a cookie cutter that's going to fit all. You have to really make sure that you're using the data to inform and support the work that you're doing, and infusing it with this equity lens to make sure that you're really achieving the outcomes that you want. So thank you for sharing that. With that, I'm going to hand this over now to Jennifer to use another section of the planner to help us to further explore the utility of the planner and the work that we're doing.
Thank you, Jenny, and thank you to everybody who's been chiming in. I can already see we have a number of leaders in this room, so I want to point you over to Section 4 in the Health Equity Planner. If you're on page 4 of that planner, you can click on the link and that will take you down to that section. And you'll see there, just like in the Social Determinants of Health section, you have some overall instructions. And then you have a series of questions under Assess, then under Plan and Test, and then under Monitor, Revise, and Adapt. And I do just want to make one point here that I think is really valuable in the Leadership and Management section. There are 3 columns. Your left-hand column gives you your questions. The middle column is department or agency, and the far right column is program or work unit. If you can answer some of these questions for both the department and the program or work unit, it can provide a lot of insight to whether you have alignment across these different areas. It can help to identify champions perhaps at the department level that your program or work unit could approach to support some of this work. So it's worth it to, even if you're just filling it out, say for your program or work unit, to go ahead and think through what that might be for your department as well. So we're going to talk a bit about considering who will champion health equity in your department or agency or in your program or work unit, and then considering how health equity gets prioritized and institutionalized in your child safety work. And I want to dive into a couple of questions here with you. And these questions are going to center on first asking, is there a designated person with authority and influence in your department or in your program who's responsible for integrating health equity into child safety work? So I know some are working toward having a particular person, or it's in somebody's job description, a title change, is there a unit? And if you look down below the slide, the left-hand side of your screen has who is the person or team to lead your initiative. So that's really talking about if you can say yes, that there's a designated person with authority or influence, or there's a department, could you go ahead and chat in whether or not you have that? And if you do, the next question is going to become, how is equity integrated? Is it widely prioritized? Do you have a strategic plan that your department is using? Do you have operational plans that have equity integrated into your activities? That's your middle chat. And then over on the far side, on the right-hand side of your screen, that's really getting at if you don't have somebody who's designated, if somebody hasn't taken on this role, if it isn't so explicit, could you brainstorm? Who could you approach? What may be some things that could work within your department or even within your work unit if you want to start there to start to advance health equity work? I see some people are going ahead and starting to chat in, and Terry has already chatted in there that there is somebody who's leading this work. So yeah, Jenny, you're right. I know you lead this, certainly, Terry, in many areas of child safety, but I'm wondering, could you join us, Terry? We'd love to hear your voice and hear a little bit more about what's going on in Tennessee.
Can you hear me?
Yes.
Okay. Using my cell phone, so just want to make sure you guys can hear me. Yeah, we've been very fortunate at the Tennessee Department of Health with some leadership in the Family Health and Wellness Division of the Department of Health to form a health equity effort. And we've been at it for a couple of years. We've had champions within the division and then have moved on up into leadership of the entire department. So we do have a health equity plan for the division, and we've implemented that. And it is a priority for our agency and our departments and our sections. We've moved forward and we've moved back. We've had some challenges with the full support. There was questions at one point, I think, when there was a federal law passed that prohibited some type of training. So there was kind of a pause where we went back and said, okay, what are we doing? And so now we have some checks and balances in place to make sure that what we're doing is approved by the department. And but it is rewarding work, and I think our sections are better for it, and I think our efforts are going to be more focused as a result. So I would highly encourage whoever, if you can get that going in your department, or even if it's in your section, just to start and do some individual training. We did both individual training, group work, just to get the basics of equity training and cultural bias and some other things. And then we started talking about implementing, policies and practices with regard to contracts and making sure that everything's has an equity focus. I don't want to give the false impression that we're perfect, because we're still a work in progress, but at least we are working toward doing that kind of work, and not just in one or two places, but over the entire Division of Family Health and Wellness.
Thank you, Terry, and I really like that comment there. I think that sometimes we become a little bit hesitant in moving forward with the work because we don't have it just perfect, or even just a tool that's just perfect. So good job to you and to the division. And I'm wondering, you were talking about policies and practices that you have in place and that there's a plan. Is this more about your internal policies and practices? And then are there plans that are specific to the different programs that you have, some operational plans where you're putting this in, or is it more as an organization as a whole? Say, for example, I know at EDC we're looking at health equity and we're saying let's have equity principles embedded in our hiring process. We have people designated to work on that. We've
discussed several different levels. One thing that we discussed was first, the contracts that we in our contract language. That was one subcommittee. We developed a reward system for people who did a project in health equity in the division. We have discussed English barrier. I'm not the expert. I wish our chair was here, but we've tried a number of things and trying to make progress in a number of areas. Again, even though we've been at it a couple of years and we can document some change, it is a long road, and I would encourage people to be patient because change is difficult in any institution. So, but those are the kind of things we've been able to do, and I'm probably forgetting something. And like I said, I wish Jacqueline was here to talk about it, but I do think we've had some success, and I'd be glad if somebody wants to email us and know more information. I can point you to our plan and stuff like that if people are interested.
Thank you so much, Terry. That's wonderful. I'm sure that everyone at CSN and a lot of folks on this call would love to see that plan. And what a great leadership approach. You offered a motivation. So a leadership practice is to motivate and to inspire your team. And by having that reward system and encouraging people and maybe making it fun, like, hey, take this on, be creative, let's do this work together, is a real show of leadership. So that's wonderful to hear. I see some more comments here in the chat. Jane, could you join us and tell us a little bit about Louisiana and the designated person at the Bureau of Family Health?
Sure. So it's very similar to what Terry explained is happening in Tennessee, and so it's across our Bureau of Family Health. We have one team that is it's called SPACE. It's our Strategy, Policy, Alignment, Communications, and Equity team, and they have a designated sort of health equity coordinator who organizes trainings, make sure that, language in different sort of job descriptions, contracts, et cetera, when we look at those types of things is kind of really reflecting what our values as an agency. And then we have within our data action team, we have a health equity sort of component, and we've created materials about how to visualize and communicate data in a way that honors, different diversities and ways to talk about and contextualize data that looks at social determinants of health and the impact of that on different communities and what contributes to the disparities that we're seeing in the data. So there's several different kind of activities that are happening, and as like Terry said, kind of a work in progress. And then we have engaged too with some of our, another consulting firm here for our whole bureau, which is about 300 people, to actually participate in sort of in DEI kind of training, et cetera. So the person who's the designated coordinator, that role is the one that logistically is responsible for all of this across the bureau, and then making sure that we're following sort of our policies when we are engaging with communities and starting some of that work. So it's pretty much the same as Tennessee, it sounds like.
That's great, and I think that you're again giving such great examples of the leadership and the management piece, and also you're providing the trainings. Language is really important. The information that you bring to the meetings is important. So by not having it just be held in one or two people's minds, and they're the ones who speak to it, you're getting it out there. You're as a culture, you start to see it, say, in your job descriptions. You start to see it in your materials. You start to embody it in a different way, and you start to have access to all of that data to inform those decisions. So I think these are all really great steps, and the point of it happening at different levels can't be stressed enough. It's a journey. I think you keep working at all those different levels and advancing the work in that way. And let's see here. I see I'm going to ask Jeannie to come off the line and talk to us, and then I'm going to ask you all to think about the integration question. So Jeannie, you're saying you have an Office of Health Equity and Disparities, but you need to see how you can work better with them. So you know who they are, Jeannie, right? Do you have are people in Nebraska sort of having some common questions, or do you know who to go to? What does that structure look like for you?
The Office of Health Equity and Disparities has been around for a long time, and we've just had a difficult time knowing how to utilize their staff, since it's a small staff that has to cover a lot of ground. And so I think, once again, this planner, I think, will have something more concrete for us to take to them and ask assistance of, you know, what we're actually wanting to do. We really don't know, you know, so I think being able to sit back and put this all down, and we will be able to have a more productive conversation than we've had in the past.
That's great. I think that's a really great point, and that is the hope with the planner, is that it is actionable, so that maybe you read one of these questions and you say, this is something that perhaps we can go to and we can ask them about, and it's very concrete, so you know they have limited resources, but you have something very pointed that you're asking. So I think that's really a wonderful way to start. I see Jenny has over here, for those who don't already have a division, a plan, something in place, what do you think you need to get this started? I can say, as you all know as well as I do, health equity, you know, the great thing is there's a lot of energy around it right now. There's a lot of positive energy to really address all of these inequities. And so you're seeing it pop up in a lot of your partnerships, in your funding opportunities. And so I think the more you talk about it and you practically think about how you address it, the better that you can partner up with different people and leverage funding for it. Are there some folks who can brainstorm a bit? If you don't already have this in place, what might you do? If you were to leave this call and you had to ask yourself, what is one thing I could do by next week to advance my health equity work, knowing I don't have a division or a department or a plan, or I don't think I do? What's one thing I could do? And it doesn't have to be a big, huge thing. Make it realistic. See if I'm going to see if I can pick on somebody, and then I'll turn it over. We're almost at the top of the hour. Let's see. Kim from Texas, are you with us? Ms. Kim. Let me see. Jeff from Rhode Island. No one wants to answer that one. Okay. Well, I can let you know.
Hi.
All right.
This is Kate Bernacki.
Oh, great. Thank you for coming in and joining us.
Hi. Yeah, I'm from California. I'm in the Department of Public Health. And I guess what I really like about what everybody is saying is I feel much more comfortable taking this plan and being able to not only bring it to, you know, my immediate supervisors and, you know, our branch chiefs, but then comparing it to our or providing it as a resource to our health equity department, and then comparing it to what we have in place already. And I'm hoping that it will provide some ability to ask questions where there's gaps, so that it can, like the person who was saying that they're not perfect, you know, it feels so new and scary to be wrong, but to me, I can use this as a basis to then ask more questions.
That's fantastic, Kate. That's right. Use it to start a dialogue, you know, and give us feedback. You know, if you think things should be added here or things should be edited or changed, we would love to hear that as you use it. I wish we had more time. We just have a couple minutes left. So thank you, everyone, for jumping in and sharing. I'm going to turn this over here. We're not going to do child safety expertise. That's another section in the planner, but we don't have time for that. Instead, I'm going to turn this back over to Maria.
Thanks, Jennifer. So here we have a couple of resources from CSN and how we can help your state and jurisdiction. So we do encourage you to check out our website, look at our publications. We mentioned a few of them earlier, like the CSN Framework and, of course, our Health Equity Planner. You can view any of our archived webinars on our site. You can join our newsletter mailing list and also view archived newsletters. and you can also request technical assistance at any time. And we know that the deadline that we had set for the Child Safety Learning Collaborative has passed, but if you are interested, we understand that between COVID and all of the other time constraints during this time of year, you may not have had a chance to get it in on time. So please reach out to us. Check out the site, the CSLC site, for more information about that. We have just launched our evaluation. So in the spirit of quality improvement, we would love to hear from you. Let us know what you liked, what you didn't like, what you would like to hear more of in future state technical assistance webinars. We really appreciate your feedback, and we do appreciate your time. Thank you for taking an hour out of your busy schedules to spend with us working on health equity. And with that, we are at the top of the hour, so we'll close out, and we hope to see you again on our next State Technical Assistance webinar. Thank you all.